Thank you very much for inviting me here in our wonderful meeting, and Dr. Kim, and also was organizing committees. So I'd like to start my talk. Okay, so today my talk is, I'm sorry for waiting for my talk. I think it's, I started my talk, evaluation of the RV functions and post-repair technology follow. So why do we need to evaluate RV functions in post-repair technology follow patient? So from clinical practice perspective, to determine the point of no return which RV can restore and recover back to normal RV function after the interventions, and prevent the deterioration of the RV functions by appropriate intervention to keep RV healthy in the long run. From the basic point of view, and understand the nature of the RV geometry and functions against loading conditions. Before we start talking about the basic nature of the RV in subharmonic positions, so basic morphology in RV in subharmonic position is a crescendo with pyramidal shape and contraction starting from the apex toward like an outflow. And RV myocardium has two layers. Inside endocardial layer is a 75% thickness and longitudinal in our river fiber orientations. In our epicardial layer outside myocardium is a 25% thickness, and this is the circumferential and also transverse directions. So circumferential fiber orientation was bring to the transverse shortening, like below-like motions, and longitudinal fiber orientation has a longitudinal shortening from tricuspid valve through the apex to or in a pulmonary valve to the apex. And peristalsis-like motions starting from the RV inflow through apex to the outflow. So time difference between starting contraction at inflow to outflow about 50 milliseconds. The summary of the basic nature of the RV contraction is a shortening of the longitudinal axis with attraction of the tricuspid valve annulus toward to the apex, and peristalsis motion from the RV inflow to RV outflow with a time difference between 20 to 50 milliseconds. And below-like motions, the inward radial movement of the RV free wall, and interventricular interaction with the bulging of the interventricular septum into RV during LV contractions, and stretching of the free wall over septums, anterior posterior directions, and of course, no torsions in RV. So the nature of the RV contraction was detected by the 2D spectral tracking. In the left side is a longitudinal shortening, and almost the 80% of RV stroke volumes was originated from the longitudinal contractions. And middle part is a transverse shortening, bulging of the RVS during the LV contractions, and stretching of the RV free wall over septum. This is 20 to 30% of RV stroke volume by the IVS and LV contributions. And right side is below motions. This can be observed and also in a 3D echo in a spectral tracking. Left side are RV contractions and right side are LV contractions. You can see in the difference between the contraction mode between the two ventricles by the 3D echo. So RV has three parts. So regional RV volume and the function was also studied. And relative stroke volume was originated from the apical sections and the inlet sections, almost 80%. So RV outflow contraction was contributed to 20% of the total in our RV stroke volumes. And RV outflow was 20 to 28% versus the inlet ejection fraction is 34 plus minus 11%. And also RV has tend to less tolerant to the pressure loading and after load than LV. So right side shows in before PA banding and after PA banding, significant reduction of the strain, peak strain compared to the before PA banding. So imaging modality to assess RV functions, you can use for the echo in a CT and MRI and nuclear imaging. Even the echo is a 2D and also 3D. Summarize for the multimodality imaging the strengths and the weakness of the imaging for RV morphology and the size and functions. I think as the 3D morphology was well depicted by the CMR and the CT, and also relatively 3D echo. And chamber kinetics was in a 2D echo was approximate in the formula, but compared to like in a 3D direct measurement by the 3D echo and the CMR and CT. And warm motion kinetics was in a 2D echo has a higher time and spatial resolutions, and CMR and CT has a higher spatial resolution, but in a low time resolutions. So this is for the example of the 2D spectral tracking for the RV warm motion kinetics in post-repaired tetralogy flow. We can just make in interest of the region of the interest, and then get some of the global strain and the free wall strain in RV. And this is for functional assessment by using for the 3D echo. Using for the 3D echo, we can measure for the volumes as well as in wall motion kinetics. And the right side panel shows we call activation imaging. This is imaging for shows you like an electromechanical propagations. So you can see, starting from the contraction from the apex, almost anterior papillary muscle area, to expand it and propagate it toward to the right RV outflow in the regions. And also you can use for like an MRI by the same spectral tracking, using for the future tracking in a way. You can get GLS and also RV area, also like volume change as well. And you can also use for the CT by the special program to cause a squeeze, and then you can get some of the volume changes, and also as well as a radial strain. Consequences after the surgical repair of the tetralogy flow. So after the repaired tetralogy flow, you may have an RV outflow stenosis and cause for the chronic pressure overload and an increase in elevating the RV pressure. And if you have pulmonary regurgitations, cause in RV dilatations and cause in volume overload, and then RV dysfunctions. And RV dysfunction was caused in RV dysfunctions as well later on. This is a summary of the reported impairment of the RV and LV mechanics in tetralogy, repaired tetralogy flow. There are many people was talking about impaired RV mechanics and RV functions, and also impaired RV mechanics and impaired LV function, as well as the interaction of the RV LV mechanics. Lots of people was reported by the strain things, like free wall in the global longitudinal strains or global area strains as well. However, this is some of the changes in RV after repair of the tetralogy flow. So RV morphology was geometry changes, but from the crescendo type to the cylinder in the bulging and the local dilatations and angle changes. And also in RV dilatation with PRTR was elevated RV EDV and RV ESV. RV contractile mode was a reduced ejection fraction, as well as in a reduced strain in the measurement. And also electropropagation was prolonged for the QRS durations, and sometimes cause an interventricular dyssynchrony. This is for the regional RV volume and the functions. Upper panel shows a normal healthy volunteer, and lower panel shows a right ventricle's tetralogy flow. So shape of the RV was more fat than in the normal one, and RV volume time curve was peak of the time shortening is less than a normal things. And also we can use this in a technique for like using for the 3D echo as well. So in repaired tetralogy flow, the global area change ratio is reduced, and also area change reduced especially for the RV inflow and outflow. I think that the right panel shows like yellow is a VS3, and also green ones are normal in a group, and red ones are tetralogy flow. You may see in the tetralogy flow was significant reduction for the inflow and outflow. Interest paper was recently published. This paper says in RV morphological geometry does the effect of RV wall kinetics in post-repaired tetralogy flow. They were divided in 5 groups of the RV shape, Let's say example of the M0 is a global increase in RV size was reduction of the longitudinal strain, and as well as in the free wall strain and prolonged the QRS duration of the RV EDV. And also the M2 has an apical bulging and RV outflow enlargement that causes an RV systolic motion reductions, and TAPC down, and abnormal diastolic hemodynamic forces. The interesting is that if you have in a dilated RV, but sometimes the RV has a shape a different way. So sometimes patient has a more bulge in the apical in a posterior parts, and sometimes more dilated in the outflow parts. So that kind of the geometric change may affect in a measurement for like strain and also ejection fractions. This is a change of the PR after tetralogical follow. I think you may know as well. So again, back to like, why do we need to evaluate RV functions in post-repaired tetralogical follow patient? So we need to determine the point of the no return, which RV can restore and recover back to normal RV function after intervention. This is a very difficult question to answer. So this is a current surgical and interventional indication for PVR, pulmonary valve replacement in a tetralogical flow. So most of the people was reported in a volume in a volumetrics in RV EDVI more than 150 to 170 millimeter per square, and also RV SBI is more than 80 cc or 90 cc per square, and RV ejection was less than 47%. This is all parameter was volumetrics. So prognostic value for normalizing the RV volume after PVR was by using for the MRIs. This paper, it reported that 158 ml per square meter of the RV EDVI, and also 82 millimeter square of the RV SBI, a cutoff value for normalized for the RV functions after the PVR. This another paper was reported, and cutoff value was different. So SBI is 120, and RV EDVI and the cutoff value was 155. But something around this and the value was the cutoff value for to get in a normal in a RV function after the PVR. So this is, according to this, in the current indication for the pulmonary valve interventions, the tetralogical flow is about the volume overload RV contractions shown in the slides, as well as the pressure overload. So because of these parameter was based on the volumetrics, so we can use for the 3D echo as well as in the MRI. So because of a good correlation of volumetrics between the MRI and the 3D echo, once the examiner was get used to it, so I think MRI has a more time consuming and also limited resources in institutions. So if you can use for a good echocardiographer to measure for the 3D volumetrics, so you may shorten the examining time and also like make the best of like outpatient clinics. Again, this is a summary of the reported impairment in RV and RV mechanics. But most of the people was reported the strain things, but you have to understand the basic strain imaging and measurement issues. So strain imaging was using for the spectral tracking and using for the optical flow and the elastic registrations, and get the data regulations and then get the strain curve. So those strain was a speckle was coming from the MRI and also in 2D echo, 3D echo, and also MR tagging as well. This is factor affecting the strain measurement. First one is temporal resolution may affect in strain imaging. So you may see in 10 frames per second is a lower one. At 80 frames per second, it has a higher in strain values. And also, layer to be tracked was different given a different result. So you have to understand where you just track the spectral tracking is very important to get a right number of the strain. And also factor affecting the strain measurement by using for a different formula. So one is the Eulerian and also Lagrangian strain computation was different results. So you have to understand what kind of the calculation was used to get in a strain curve. So because this causes in a wide variety of the normal value of the LV strain from the healthy subject. So different in each modality. So you may see a different variety of the normal range using for the 2D speckle and 3D speckle and so on. The position of the strain on the evaluation for the RV function is repeated as follows. Many strain study has been reported by the various imaging modalities. However, the values are not consistent with wide variations. To use the strain data as prognostic measure for detecting the timing for the PVR, strain measurement must be standardized by overcoming the intrinsic issues which strain measurement has. The issue when evaluating RV function in post-repaired temperature follow is we have to understand the natural history of the RV size and functions in normal healthy people, especially in the light of the aging. And also, natural history of the RV size and function in the super patient after pairing temperature follow without any event compromise. And also, last one is which modality and method to assess RV size and functions. This is normal value for the 3D RV size and functions, total 1,051, and there was difference between the men, gender differences. The RV-DVI is almost 155 for men and 170 for the women. And this normal value was 3D RV size and function are different at each ages. RV-SV and RV-EF is slightly decreasing as aging, while RV-EDVI and RV-ESVI are stable. And changing with the aging on normal value of the 3D RV size and functions, aging change of volume time curve was plotted in this slide from the under the 30 years old and over the 70 years old. I just overlay for the under 30 years old and 70 years old. The blue one is under 30 years old, red one is 70 years old. So I see even a normal healthy population was age dependent is the volume time curve was obtained. So natural history of the RV size and function in the super post-repaired fontan. Unfortunately, no data is available for the super post-repaired fontan like a super in a fontan. Just in the picture was shown, reported by the Dr. Ochi was he used for the excellent super fontan for the blue dot, and non-excellent fontan was a red dot. And 2 years after the fontan operation, he just measured for the hemodynamics compared to those two groups. But no definition of the super post-repaired follow was yet. So maybe we have to understand the super tetralogy follow patient was how changed his RV and also how changed RV functions. The summary, the characteristic of the RV contraction as R is mainly the longitudinal in the contractions, especially when the inlet and trabecular part, in the circumferential and the contraction is outflow, and peristaltic movement, and the below movement, and the stretching of free over the septum, stroke volume generated by the inlet and apical segment about 80%, and circumferential in our contraction is increased when RV dilated, and the RV size and functions repaired fontan as shown in the slides. And then in conclusion, in clinical perspective, evaluation for the RV size and function by measuring RV volumes and RV ejection fraction, either by MRI or by the 3D echo, is consistent and standardized as a prognostic value for the PV interventions with the care of the age and gender associated changes for the time of being. And strain measurement, like a global longitudinal strain, is promising, but still need to be standardized enough to use as a prognostic value in the clinical practice, including imaging modality or the way of the calculations. So thank you very much for your attention.